Hello everyone, welcome to the part 5 of Advanced Pharmacology. This is video crash class for MRC Psych Paper A and I'm Lena Palaniappan. Let's start with the first EMI, drug interactions. We have to choose agents that have clinically significant interaction for each of the description given in the list. Question number 1, a 45-year-old patient is an enthusiastic naturalist and is keen on drinking grapefruit juice for breakfast. Choose two interactions. So we have to choose two interactions with grapefruit juice. Grapefruit juice has a chemical called naringenin. This naringenin can increase bioavailability of several drugs by downregulating intestinal, but not the liver CYP3A4-1A2 system. The cytochrome P450 system is present in the liver as well as gut mucosa. Naringenin has a particular effect on the mucosal cytochromal P450 system. So this effect is greatest for calcium channel blockers like felodipine, nimodipine, anti-epileptics like carbamazepine, benzodiazepines like triazolam and midazolam, and to some extent diazepam, simvastatin, and also methylprednisone. Buspirone and pimozide are also other psychotropics that are significantly affected by grapefruit juice. Now, grapefruit juice, the chemical naringenin also has another peculiar effect. It increases a particular glycoprotein on the gut mucosa called P-glycoprotein, as you will see in this picture taken from Medscape. Um, P-glycoprotein gets inserted on the cell membrane of the gut mucosa. Now, this P-glycoprotein is like a aqueous, like a leaky pore. When you have P-glycoprotein, actively the drug chemicals that are absorbed into the cell will be pushed out. So you absorb the drugs through the gut mucosa into the intestinal epithelium, and you want them to go to the other side, to the systemic circulation. But if you are inducing P-glycoprotein production, this P-glycoprotein will actively take these drugs and secrete them out. Antibiotics can be affected in this way. So it's important to make sure that if a patient is drinking a lot of grapefruit juice, adjust for the dose of possible interacting drugs. So from this question, from this list, the answer is likely to be pimozide as well as carbamazepine. Okay. Question number 2. A 35-year-old patient is on long-term NSAID therapy for an ankle injury. Choose one drug from this list that could interact with it. Now, as you know, NSAIDs and NSAIDs and lithium, they interact with each other. NSAIDs can reduce the renal elimination of lithium. This can increase the steady-state plasma lithium concentration, which means the risk of lithium toxicity is higher in patients taking NSAIDs. This usually happens over 5 to 10 days after adding an NSAID or an ACE inhibitor. Angiotensin converting enzyme inhibitors can also have the same effect as NSAIDs. They reduce lithium clearance because they induce a degree of sodium depletion. So both of them can increase lithium levels over 5 to 10 days. It's better to avoid these drugs, monitor lithium more closely if these drugs have to be used, and reduce lithium dose if needed. What are the other medications that could increase serum lithium levels? Diuretics, both loop and thiazide diuretics. So here, question number 1, the option would be C and H, carbamazepine and pimozide, as we discussed earlier. For question number 2, NSAIDs are likely to interact with lithium in the given list. So option A for question 2. EMI2 mechanism of action. Now we have to match the described mechanism of action with the drugs in the list. Number 1, selective norepinephrine reuptake inhibitor. So selective norepinephrine reuptake inhibitor is a reboxetine. Reboxetine has a specific side effect profile as well that is linked to the noradrenergic system, and that is urinary hesitancy. This is observed in around 1 in 10 patients, especially male patients who took part in clinical trials. And we can give relief from the side effect by using tamsulosin, an alpha-1 blocker, or doxazosine, which is also an alpha-1 blocker. Urinary hesitancy is similar to what happens when you have a benign prostate hypertrophy. So using drugs that are used for BPH is helpful to abate the side effect of reboxetine. And this is all happening because it's a noradrenergic drug. It's a selective norepinephrine reuptake inhibitor, similar to atomoxetine, which is used for ADHD. So question number 1, the answer is reboxetine. Question number 2, melatonin agonist. Which in the list is a melatonin agonist? Now, we have only one melatonin agonist that we use in psychotropic therapy now, psychiatric treatment now, and that is for depression, that is agomelatine. Of course, melatonin is a direct melatonergic agonist, which we use for hypnotic purposes. But for antidepressant purposes, the only melatonergic drug we have is agomelatine. And what does agomelatine do? Agomelatine blocks a receptor called 5-HT2C. What is the function of 5-HT2C? Normally, when you stimulate 5-HT2C, it will end up in stimulating an inhibitory neuron called GABA interneuron. When you stimulate an inhibitory neuron, it's going to reduce the overall excitation. And this particularly reduces the excitation of noradrenaline dopaminergic release neurons. So you'll have less noradrenaline and less dopamine when you stimulate 5-HT2C. So if you block 5-HT2C, what will happen? Agomelatine blocks 5-HT2C. When you block that, this inhibition effect is gone. In other words, you're getting a disinhibition effect with agomelatine. This disinhibition means there is increased excitation and there is increased monoamine release, and this is what you need to treat depression. Melatonin receptor MT1 and MT2, the actions of agomelatine on these receptors, we do not know if they directly contribute to antidepressant effects or not. So for question 2, it's agomelatine. For question 3 and 4, we will consider them together because the answers are very similar. The theme is very similar. Question 3 is D2 partial agonist. Question 4 is asking for a 5-HT1A partial agonist. So which one in the list is a D2 partial agonist? Let's look at all the partial agonists that we know in psychiatry. Aripiprazole is a partial agonist at D2. It's also a partial agonist at 5-HT1A. Buspirone is a 5-HT1A partial agonist. Varenicline, used for smoking cessation, is a nicotinic alpha-4 beta-2 partial agonist. Cariprazine is a unique D3 partial agonist. It also has D2 action and 5-HT1A action, all partial agonistic actions. Buprenorphine is a mu opioid partial agonist used in opioid maintenance therapy, substitution therapy. Brexpiprazole is also an antipsychotic, which is similar to aripiprazole in its profile. It's a D2 5-HT1A partial agonist. So this question, D2 partial agonist would be aripiprazole. We don't have brexpiprazole listed. We don't have cariprazine listed. And 5-HT1A partial agonist is likely to be buspirone. Now, aripiprazole is also a 5-HT1A partial agonist, but if they ask for only one option, better to choose the one which is primarily acting through 5-HT1A partial agonism, and that's buspirone. So just reviewing all of the answers for this EMI. Question number 1, selective norepinephrine reuptake inhibitor is reboxetine. Question number 2, melatonin agonist is agomelatine. Question number 3, D2 partial agonist is aripiprazole. Question number 4, 5-HT1A partial agonist is buspirone. Question 3, adverse effects. For each of the drugs given below, identify the main side effect: paroxetine, lithium, amitriptyline, lamotrigine, sodium valproate. Now, paroxetine can often cause dry mouth because of its anticholinergic property. Another drug with anticholinergic property here is amitriptyline. All tricyclics have anticholinergic effects. They vary in the degree of anticholinergicity, but amitriptyline has a high anticholinergic side effect profile. It can cause dry mouth, constipation, urinary retention, and blurred vision. Now, this is a slide explaining multiple receptor effects of tricyclics. As you will see, it produces M1 blockade, which causes anticholinergic delirium. It also causes peripheral M2, M3, M4 blockade. All antipsychotics have some profile of blocking M2, M3, M4, which is the peripheral anticholinergic effects that you see in patients taking these medications even in therapeutic doses: constipation, blurred vision, dry mouth, and urinary retention. Of course, their main action is antidepressant action, that is by blocking the serotonin and norepinephrine reuptake transporters. They also have alpha-1 blockade, H1 blockade, and 5-HT2A2C blockade effects. Let's look at lithium and skin. Lithium can exacerbate pre-existing psoriasis. It can also induce new onset psoriasis, and it can also convert existing psoriasis into a pustular form. It can produce nail changes, and it can even induce psoriatic arthropathy. This can occur even at normal therapeutic serum lithium levels. The mechanism is not known, but lithium can increase the proliferation of epithelial cells, and it can also induce pro-inflammatory cytokines. So these are suspected to be the mechanisms, but we are not sure. The exacerbation of psoriasis can occur very soon after starting lithium, days to weeks, but new onset of psoriasis may take longer time to occur. Lithium-induced psoriasis, unfortunately, is often treatment resistant. Reducing the dose or stopping the treatment, lithium treatment, may be needed to bring psoriasis under control. Another skin problem is a rash that we see with lamotrigine. The lamotrigine-induced rash happens in 1 in 10 patients. It's 10%. But only a few of these rashes will be indicators of more serious malignant skin problem called Stevens-Johnson syndrome, so less than 0.5%. But it's hard to know which rash is Stevens-Johnson rash and which is not. I have some indicators here, but it's better to consider stopping the treatment when you see a rash in a patient who's taking lamotrigine. The feature suggestive of Stevens-Johnson syndrome includes systemic problems like fever, elevated white blood cells, elevated liver enzymes like AST and ALT, involvement of mucosa or the face with the rash appearing dark red or irregular in shape, expanding or being painful and oozing or peeling away, all indicating inflammatory activity. So these problems suggest that it's better to stop lamotrigine. Stevens-Johnson is a fatal problem. Okay, so continuing on with skin problems, now we move on to hair loss problem that happens with sodium valproate. There's an extensive literature in epilepsy. When you treat people with sodium valproate, there is reported hair loss. Not a lot of literature in bipolar disorder, but definitely, patients with bipolar disorder are not immune for hair loss. There are a lot of reports in the literature, mostly anecdotal. Incidence is around 1 to 3%. The mechanism is not clear, but biotin deficiency and metal chelation effects are suspected. The effect appears to be dose dependent. Higher the dose, the more chances of hair loss. And it appears to be reversible. In many people, it grows after a while and affects both sexes. So here you have an example of a patient, it's actually an epileptic patient, but valproate was started at 500 milligram. After nearly a year, she started showing, in the first year, she started showing some thinning of the hair and some spots of alopecia. And then she started having curling of the hair. And then it kind of peaked, less curling and then less curling. And overall, finally, her hair was more or less restored after continuous therapy. So there is a spontaneous reversal that happens in some patients. Incidence is higher from 3 months of treatment, though it may be late in some people after 1 to 2 years. Younger patients have higher incidence of hair loss and curling. So paroxetine option is C, anticholinergic effects. We have reviewed dry mouth problem with paroxetine. With lithium, we can choose worsening of psoriasis. With amitriptyline also, we can choose what we chose for paroxetine, anticholinergic side effects. For lamotrigine, we can choose option I, actually, not J, sorry, option I, Stevens-Johnson syndrome. And for sodium valproate, we can choose, question number 5, sodium valproate, we can choose hair loss or alopecia. Please change option I for 4. It's actually Stevens-Johnson syndrome. Next question, EMI 4, agonistic agents. So we have a list of agonists and we have to match them with the receptor profile. Oxycodone, zolpidem, bromocriptine, pramipexole, and vortioxetine. Oxycodone is a full opioid agonist with no antagonistic properties. It has an affinity for kappa receptor, mu receptor, and delta opioid receptors in the brain. Zolpidem binds with high affinity and acts as a full agonist at GABA A receptor. All Z drugs act on GABA A receptor system. Bromocriptine is a dopaminergic drug, as you know. Pramipexole, bromocriptine, pergolide, ropinirole, all used in Parkinson's. They're all dopamine 2 receptor agonists. You can also use them in hyperprolactinemia. What is vortioxetine? It's a new antidepressant, fairly new. It's a multimodal agent It's an antagonist at serotonin 5-HT3 receptor. This enhances the release of 5-HT, norepinephrine, as well as acetylcholine. It also targets the serotonin transporter like any other SSRI. So this is probably its primary mechanism of action, targeting serotonin transporter, but has a unique profile on 5-HT3 system. It's also an agonist at 5-HT1A, and this may be helpful to treat anxiety, just like buspirone. It's a partial agonist at 5-HT1B, and it's an antagonist at 5-HT1D, 5-HT3, and 5-HT7. The 5-HT3 antagonism may actually enhance the release of monoamines. So oxycodone, option D, which is mu receptor agonist, zolpidem, GABA A agonist, bromocriptine and pramipexole, both of them are dopamine D2 receptor agonists. Vortioxetine, we can choose serotonin 1A agonist. Serotonin 3 antagonism, but serotonin 1A agonism. That's for vortioxetine. 5, anti-dementia drugs. So for the anti-dementia drugs given below, identify their mode of action. So each of them, they require 2 answers from us: galantamine, memantine, and rivastigmine. Let's review the mechanism of action of anti-dementia drugs. Now, most anti-dementia drugs increase the availability of acetylcholine at the synaptic level. So donepezil, rivastigmine, galantamine, all of them increase the availability of acetylcholine. How do they do that? They actually block an enzyme called acetylcholinesterase, which breaks down acetylcholine to choline and acetyl coenzyme A. This breakdown happens in the synaptic cleft. So by blocking the acetylcholinesterase enzyme, you're increasing the life of acetylcholine molecules. There's also one more enzyme that breaks down the acetylcholine released in the synaptic cleft, and that enzyme is butyrylcholinesterase. Sometimes it is called pseudocholinesterase. It's present in the plasma. It's also present in glial cells. Unlike acetylcholinesterase enzyme, which is present in the neuronal, tagged with the neurons, the butyrylcholinesterase is tagged with glial cells. So anti-dementia drugs like donepezil, galantamine, the rivastigmine, they all block the acetylcholinesterase, but they all block in slightly different way. Donepezil and galantamine, both of them are selective for acetylcholinesterase, and they are reversible and non-competitive inhibitors. They are reversible because the action, after a while, the action is lost. So they are reversible and they are not competitive. But galantamine has an additional action. Unlike donepezil, galantamine has an additional action, as you see here. It does allosteric modulation of the nicotinic channels, nicotinic acetylcholine receptors, which means it actually directly stimulates the nicotinic receptors. So it achieves the effect that acetylcholine will achieve to some extent. This is helpful because it produces a stimulating effect, alerting effect in some patients. So this is only seen in galantamine, the allosteric modulation of presynaptic nicotinic receptor. You also have a dual action with the rivastigmine. Dual action with the rivastigmine. It blocks acetylcholinesterase as well as butyrylcholinesterase. So you see rivastigmine having dual action for both of them. So these are the mechanisms of action. Remember, donepezil is selective, reversible, non-competitive. Rivastigmine is sometimes called pseudo-irreversible because it's slow. It takes longer time to reverse the actions of rivastigmine, even though its half-life is short. So rivastigmine is pseudo-irreversible. Galantamine is like donepezil, it's selective and reversible. What is memantine? Memantine acts through non-competitive NMDA receptor antagonism. So rivastigmine is non-selective inhibitor of both acetyl and butyrylcholinesterase. Galantamine is competitive. It's a selective and reversible inhibitor of acetylcholinesterase. It's also a nicotine modulator. Memantine is an NMDA receptor antagonist and a weak 5-HT3 receptor antagonist as well. That 5-HT3 action probably doesn't contribute much to dementia treatment. So question number 1, answer is A and C. Nicotine receptor agonist as well as a reversible competitive inhibitor of acetylcholinesterase, that is galantamine. In that way, it differs from donepezil. Donepezil is non-competitive, even though it is reversible. Memantine is going to affect glutamate transmission because it affects NMDA receptors. So you can choose F and K, NMDA antagonism for memantine. For rivastigmine, you have to choose G, which is reversible non-competitive inhibition. In that way, it's similar to donepezil. Plus, you should also choose butyrylcholinesterase inhibition because it's a dual action agent. So now receptor mechanisms. Um, for the following side effects exhibited by the drugs, identify the receptor action responsible. Number one, a 40-year-old woman on fluoxetine developing nausea and vomiting. Number two, a 65-year-old woman complained of excessive sedation on trazodone. Number three, a 33-year-old gentleman dry mouth on amitriptyline. A 23-year-old woman developed weight gain and sedated on mirtazapine. So let's start with the first one. SSRIs such as fluoxetine, they cause GI side effects because they stimulate 5-HT3 receptors. 5-HT3 receptors, when you stimulate them, they can increase the visceral sensitivity, emesis, vomiting. They can also increase gastric emptying. So all of these are actions of 5-HT3 receptors. When they're stimulated, you'll have diarrhea, nausea, increased peristalsis. So option D, 5-HT3 agonism is the reason for gastrointestinal side effects of SSRIs. Question 2, a 65-year-old woman having sedation on trazodone. How does trazodone act? Trazodone causes sedation primarily by alpha-1 antagonism as well as H1 histaminergic antagonism. It also produces 5-HT2A blockade, which might contribute to some of the sedation, but alpha-1 and H1 system, they primarily produce sedative effects. Antidepressant effects of trazodone is mediated by serotonin reuptake inhibitor, transporter inhibition, and also 5-HT2A and 5-HT2C antagonism, and this happens at higher doses. Side effects like priapism, orthostatic hypotension, these occur due to alpha-1 adrenergic antagonism. Remember, the alpha-1 antagonism is actually relatively lower compared to 5-HT2A effect. This is why the side effects are not as common as the beneficial antidepressant effect. So question number 2, option A, 5-H1 antagonism can be chosen for reason for sedation. The given alpha-1 blockade, you could choose that as well, but in this option, you don't have that. So go for H1 antagonism. Dry mouth on amitriptyline, we have seen this before. It is because of peripheral antimuscarinic effects. Tricyclics cause antimuscarinic, anticholinergic effects. So we can choose the option H, M3 receptor blockade. Which one is important, M2 or M3? Actually, M3 seems to be important for dry mouth because salivary glands seem to have M3 receptors. So please choose M3. Question 4, a 23-year-old woman, developing weight gain on mirtazapine. So what is the action of mirtazapine? Mirtazapine primarily blocks the alpha-2 heteroreceptor. This is why it's called NASA, noradrenergic specific serotonergic antagonist. So the noradrenergic antagonism is blocking alpha-2 heteroreceptor, which increases serotonergic activity and produces antidepressant effect. Now the alpha-2 is also an autoreceptor. By blocking the autoreceptor system, the alpha-2 system, mirtazapine will also increase noradrenergic transmission. So both serotonergic and noradrenergic transmission are increased by mirtazapine, and these are the primary reasons for antidepressant effect. But it can cause weight gain by having an effect on the H1 histaminic system. It's an antihistaminic drug. It blocks the H1 receptor, and this can cause sedation, appetite increase, weight gain, and dry mouth as well, H1 blockade. It does block 5-HT3 as well, unlike SSRIs. So mirtazapine is better to be used in oncological setting, in cancer treatment when people are depressed. This doesn't trigger the chemoreceptor zone, so it reduces the nausea. It blocks 5-HT2C. This may also contribute to antidepressant effects. It blocks 5-HT2A, which reduces akathisia. So option A for weight gain, H1 antagonism is the contributing factor for weight gain. So reviewing all of those answers, fluoxetine and nausea is 5-HT3D. D is the option. Trazodone and sedation, H1 antagonism. Dry mouth and amitriptyline is M3 M3 blockade. Weight gain on mirtazapine can also be attributed to H1 antagonism. EMI 7, receptor pharmacology. Which of the listed terms best describe the receptors relevant for pharmacological action? D2 receptor. What kind of receptor is D2? D2 receptor, the dopamine D2 receptor, it belongs to the family of 7 transmembrane domain G protein coupled receptors. It's highly expressed in CNS and the pituitary gland as well. So this is the 7 you can count, it'll be 7 actually. So transmembrane spanning domains, and you have a second messenger system attached to it. So this is how D2 receptors work. They are um, metabotropic. So question 1 will be 7 transmembrane receptor. Question 2, glucocorticoid receptor. Let's see how glucocorticoid receptors function. The glucocorticoid receptor is also known as NR3C1, nuclear receptor, NR, nuclear receptor, subfamily 3, group C, member 1. So it's actually a nuclear receptor, but it is not located in the nucleus. It's important. They're located primarily in the cytoplasm with several other proteins, including the heat shock protein system. When it is activated, when the ligand gets bound to it, when glucocorticoids bind to the glucocorticoid receptor, this receptor system then translocates to the nucleus and starts regulating gene transcription. So membrane-associated corticosteroid receptors also exist. So you can see in this picture, this picture you can see there's one membrane-associated receptor, um, but most of them are here in the cytoplasm. So when they are bound, they're associated with heat shock proteins. When they're bound by glucocorticoid molecule, they move into the nucleus and regulate gene transcription. Depolarization triggers activation of this receptor. What receptor is triggered by depolarization? So you have voltage gated ion channels. So what are voltage gated ion channels? You have a little blockade, like somebody keeping the gate, a gatekeeper, and that gate is opened when there is depolarization. So when the voltage inside the cell is minus 70, they're closed. When it's minus 50, which means it's more positive now, less negative, more positive, depolarization has happened, then they open. So these are voltage gated ion channels. They're opened by depolarization. Then you have GABA A receptor complex. What is the description suited for GABA A receptor complex? GABA A receptors are interesting. They're rosette shaped. They have multiple subunits. They have 2 alpha, 2 beta, and 1 gamma subunit. When they are activated, they open a chloride pore, and chloride ions can enter the cell. But GABA itself binds in only 2 places of this rosette-shaped receptor. These are GABA binding sites. You can see them here. But there are many other allosteric sites, which are regulatory sites that are away from the agonist site. But when you stimulate those regulatory sites, you can control the effect of the ion channel. So there's a benzodiazepine site, there is a Z-drug site, there's a site for alcohol, barbiturates. So all of this is called allosteric modulation. GABA A is an example of an allosterically modulated receptor. Finally, a receptor that regulates the synthesis of mediators other than its own ligand. So this is a receptor that mediates the synthesis of um, uh, chemicals other than mediators other than its own ligand. So when you stimulate it, it should modulate the release of something different from what stimulated it. These are called heteroreceptors. So examples are given here. Alpha 2 receptor system is a heteroreceptor system. 5-HT1A receptors could be heteroreceptors as well. Alpha 2 receptors are located presynaptically on adrenergic neurons, which is autoreceptors, but sometimes they're also located in other neurons like dopamine, serotonin, glutamate neurons. So when you stimulate them, they will inhibit the release of these other chemicals like dopamine, serotonin. This is how mirtazapine acts. Mirtazapine is a heteroreceptor mediated antidepressant. So in this picture, what I've shown here is when you stimulate alpha 2 receptor, it generally reduces dopamine in the prefrontal cortex because it's a heteroreceptor with inhibitory effect. So when you block the alpha 2 receptor, it increases dopamine availability. That's what mirtazapine does. It increases monoamine availability through the heteroreceptor system. This is a mouse brain. So as I said, these receptors, heteroreceptors, are also autoreceptors. Whether you call them auto or hetero depends on their location. If they're located in the same neuron that releases it, that's called autoreceptor. If they're located in a different chemically mediated neuron system, then they're called heteroreceptors. So question number 1, dopamine D2 receptor is 7 transmembrane. Glucocorticoid receptor is a nuclear receptor. Depolarization triggers activation of voltage-gated ion channel. GABA A receptor complex is an allosteric, has an allosteric binding site, has many allosteric binding sites. A receptor that regulates synthesis of mediators other than its own ligand is a heteroreceptor F. Thank you very much.